inhibition of angiogenesis doesn't last forever, right? What do we know about mechanisms of resistance to antiangiogenic drugs?
So that's a tough question.
That's why I asked it.
Yes.
You get all the good questions.
So part of that might be related to the lack of biomarkers for what types of patients, what types of tumors may be sensitive to antiangiogenic therapy. In gastric cancer, the AVAGAS study was a large 700-patient study, and 90% of patients did provide tissue samples. And we were able to look at two candidate biomarkers. One was plasma VEGF-A, which is the ligand for bevacizumab, and then neuropilin-1 expression on the tumor cells, which is a co-receptor for VEGFR1 and R2. So these are both sort of candidate biomarkers for the efficacy of bevacizumab. So a postulate might be that other mechanisms of angiogenesis might play a role for when patients fail bevacizumab therapy. I think that for ramucirumab, from the REGARD and RAINBOW studies, the biomarker analysis is just now being completed, and they haven't identified a biomarker that actually demonstrates sensitivity, much less identifying mechanisms of resistance.
Yeah.
But interestingly, building on the VEGF-A point, there's data to suggest that in patients outside of other treatments, if you just look at the blood samples of patients in the West versus East, the Western patients tend to have higher level of VEGF-A, and actually stage for stage, again, the patients with higher VEGF-A tend to do worse. Again, perhaps validating the observation that VEGF inhibition is more important in the West.
So Roy, in lung cancer, the biomarker's been elusive today.
Right, it's hard because as I said earlier, you're not looking only on the tumor, you're looking at the endothelial cells, and biopsies are hard enough to come by. A little bit better now in this era of molecular targeted therapy. But really, it's been very hard to identify what is the right marker, how do you measure VEGF. With the antibodies, you always had the concern, are we truly blocking, all the VEGF? It's more of a trap, right? Because you have the VEGF ligand interacting with the receptors. So, do we know we're even using the right dose, that we're getting it to the tissues, that we're having an effect? I think in all the time, and I've used the drug bevacizumab, and I did the first early phase 1 with the group at MD Anderson, seeing maybe one patient have a frank response as a single agent. So really, how it's working, it's sort of working as an enhancer with chemotherapy. So it's really hard. And I think what we've seen now as we've talked, and this is a good review for me too, that it works in some areas really well, and in some areas it works okay, and in some it doesn't work. When you see something like that, it tells you that there's a population that's benefiting, but we just can't pick it out. But I think that now there'll be some new life. These agents will be important to test with the immunotherapy platforms, which are moving into the front line and second line. And also, let's not forget that there are other mechanisms. Isn't there a drug, Johanna, that you're studying, now that actually targets like an old TNP 470 analog, right?
Yeah, the fumagillin analogs, and certainly multiple different ways we're going off after the angiogenesis pathway, aside from just attacking VEGF. So a lot to come, and targeting the TIE2 receptor, all different types of ways to get a better walk on the angiogenesis pathway.
Right, so I know of this drug, but we're not studying it. That's why I didn't want to. But I think it's definitely important that there are now other ways of more directly targeting angiogenesis. Looking at, microenvironment is going to be critical. So, when we talk about microenvironment, these are agents that target the microenvironment.
And if I may add to this point, I think the challenge with the VEGF biomarker is that it's probably not a simple tissue biomarker. You can't just rebiopsy and find EGFR or HER2 or T790M. I think it's a more dynamic biomarker. It's in the bloodstream. And as our technology evolves, every year there's a new circulating DNA test or liquid biopsy test. So as our technology evolves, we will be able to find it, but it's likely more of a dynamic biomarker.
I mean, obviously the mechanism of action of at least of the antibodies is mostly ligand directed. I mean, obviously the receptor binding is to prevent ligand receptor interaction. How much do we know over the life cycle of the tumor issues about the ligands. I mean, there are a number of different pro-angiogenic ligands.
Right, well, of course, it's like in any biologic system, you block VEGF, you're going to increase BFGF.
Yeah.
And, we've not been that successful at blocking that, at least in the lung cancer studies that we've looked at.
Yeah.
So that's the thing. You have to look at the whole milieu and really think about, blocking multiple pathways. So, but it's progress, and it's good. It's good that these drugs are available, and I'm actually impressed with how they seem to work much better in the GI tumors than in lung. But in lung, we have it for certain patients, which is great.